So here we are after the superb demonstrations of all the meniscus. We are in the PCL session, and I would be demonstrating the PCL reattachment. Of course, the PCL of this gentleman is intact, so I'm going to be in situ demonstrating the PCL reattachment technique. Now, first and foremost, I would like to thank Dr. Sharath and the entire organizing team for hosting this wonderful event. And it was lovely to see all the doyens of arthroscopy of Karnataka this morning present there with all the enthusiasm and zeal. Now, this basically, I'll run through the few steps. While we were waiting for all of you guys, we have done a few things here. I have Dr. Sumant, Dr. Akshay, Dr. Pratima, and half Dr. Madhuri assisting me for the case, which will probably make my things easier. Quickly, let me run about the portals. Am I clear here?
Yeah, Chirag.
Yeah, if the vision is clear, let's quickly look into the outside picture, please. So in a PCL, by rule, I take 4 portals, maybe PCL attachment, PCL reconstruction. I would take a standard anterolateral portal here. I would take a kind of a lateralish and a superiorish medial portal, which will be more towards the midline. Outside picture, please. I would take a standard posteromedial portal, and I would take a posterolateral portal. Now, let me look at the picture inside. This is my ACL and PCL. How do I put my scope into my posteromedial portal? I would drop my leg down. This will give me a better trajectory to enter the scope. Flex it a little bit, please. Since this is a cadaver, it's a little tight. Okay, can you see this? I have easily entered my scope through the ACL and PCL window. The window what I've created here is between the ACL and PCL. Can you see that? That's the ACL on the lateral side, there's the PCL on the medial side. I seep in my scope here inside, and I'm in my posteromedial compartment. Now here, I would then flex my knee to 90 degrees and then readjust my scope according to my needs. Here we are. I have already put the portals. I've already put the cannulas. If I can just run through a few things here, okay, a few landmarks to be kept in mind. One, as we enter here, you will find a fold of synovium, and my portal will be superior to that. Can this be appreciated?
Yes, Chirag.
Yeah, so this is the synovial fold, and my portal, posteromedial portal, is just above that. Of course, this is a cadaver, so it's not that great, but of course, we can well appreciate that. Next comes the root of the medial meniscus. If one can appreciate here, the root of the medial meniscus is seen here, and that is a medial femoral condyle. So this is a triangle I form, and my scope will be here. Next, what do? I need to have a portal on the posterolateral side. So give me a Wissinger rod, please. So keeping this portal intact, I would then take a Wissinger rod, the sharper end of that, I would introduce it through my posteromedial portal, and then just go, and hit a spot on the posterolateral side. Can I have this picture outside, please? On the lateral side, please. Camera 2. Fantastic. No, camera 2, here. Huh?
Yeah.
It's been shown? Fantastic.
No,
So
we
this is
can't
where
see
it
that.
comes. The landmarks what I need to keep in mind is my biceps tendon here, and my peroneal nerve will be below that. So until unless I'm above that, in this sweet spot, this is my fibula head, this is my biceps tendon, that's my common peroneal nerve, and I'm in that sweet spot where my trajectory is right. Can you see that inside picture? When I put in my scope here, I should just be flush to the posterior part. Now, what next I do? One would like to, hey, no talking, please. I would like to release my posterior capsule. This is the most important trick, and this is the most important step. So as we're working here, I would put my Wissinger rod through my posterolateral portal, who ask my assistant to hold the capsule out so that I do not damage any neurovascular structures. Then I put my RF here, enter the RF through the posteromedial portal, visualizing I do not have a 70-degree scope here. If somebody has a 70-degree scope, that would be ideal. I would then probably start releasing the capsule way down. You may encounter some small bleeding here, small bits of bleeding. Since I've already released this, it's a good habit to keep your RF probe facing towards yourself so that you do not damage any sort of neurovascular structures. I would then release the capsule, release the capsule, release the capsule, go down, go down, go down till I see my, can you see that? That's my soleus. Can you see that?
Yes.
Can I get a revert back
Yeah, Chirag,
from
we
the,
can see that.
yeah, fantastic. So if there are any queries here, I could take that. Dr. Rohit, Madan sir, anything added on at this point, I would be glad to take the feedback and I probably would do that accordingly. So we clear out that, clear out that, clear out that. Now, what do we do next? I would remove my scope from here. Put a Vicinger rod, please. Shift my scope. Since I have my cannula in place, it becomes easier for me to shuttle my scope in and out as in where I want to see. Okay, here I am viewing to the posterolateral portal. That is the PCL stump. If somebody can appreciate that, that's my PCL stump. So I would take a probe. Can somebody see that PCL?
Yes,
I
Chirag.
usually take a posterolateral portal because from here, I'm visualizing it end on. I am not using that driving in the wrong side. I am driving in the right side. I am seeing this portal from this portal as it is. That makes my body and mind work in sync rather than having a mirror image which is seen on the posteromedial portal. If you see here, this is the footprint of the PCL, and I would like to go still a little lower and clear out these tissues. We will do that. Shaver, please. I'm using a shaver here because these are tough tissues. I'm not able to get rid of them so easily. It's a cadaver, but kindly make sure that you're not using the shaver very aggressively when it's in a live surgery of a alive individual. Okay, I'm just making things faster here. One could well use an RF probe and kind of release all these fibers, release all these adhesions. I'm going down. My visualization should be as much as 1 centimeter below the joint line. Here we are. Now let me just quickly look at where the joint line is. The joint line is somewhere there, and I am well below that. That should be good. I can now take a jig. Can somebody give me a jig, please? I will
Chirag,
shift my
before
portal
placing the
again. So the only
Chirag,
thing
can you
about
hear
this,
us?
yeah.
Chirag, before placing the jig, can you show the landmarks once?
Landmarks
Posterior.
of the PCL.
Yeah.
Yeah. So definitely, I would love to do that. So here we are. I am in the posterolateral portal. Through the posteromedial portal, this is the root of the medial meniscus. This is the medial femoral condyle, and that is the PCL stump. That is the PCL stump here. That's
Okay.
the PCL stump here. That is the PCL stump here. We need to remember that the PCL, as we saw in the talk, what Dr. Beliapa beautifully described the anatomy of the PCL. PCL is a wide kind of a reverse champagne bottle structure, which has a broad attachment to the tibia, and that spans beyond the midline. It is the 30% of your fibers or 50% of your fibers is past the midline. So it's very important that we clear out these inter septum of the two chambers and then go past midline. Here I'm going past midline. That's your capsule. That's your PCL. If you want to see the PCL, I will demonstrate that as well. This is a PCL fibers. Can we see that? That's the PCL fibers running there. It's a
Yes,
degenerative
Chirag.
knee, so it may not be as good as an individual. So can you see that? That's a PCL fibers, and that's where we are. Okay. So now let me quickly shift. I'll just clear off these debris. Let me make visualization a little better. Let me just clear out this debris, clear out this debris. A little tough tissues here since it's a cadaver, but I'm okay. Great. That goes there. I'm able to kind of Are we able to appreciate? There's a little bit of fatty infiltration into the PCL, but if you see this kind of mild vascularity there, that's your PCL. That's your PCL. That's your PCL fibers. Here we are. Let me just clear out this as well. Let me just clear out a little bit of this debris. I'm going down the capsular attachment. Dr. Sharath has graciously given me 20 minutes to finish the surgery. So let me see if I can speeden up. Here I am. That's the capsule. I'm going down, 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 down here, resecting out there, using that fibers. That's my capsular attachment to the PCL, just below the PCL. And here you are, soleus. So I am good with this release. I wouldn't want to release much for the benefit of the youngsters. See my probe. Probe is always facing towards the articular surface. It's never facing outside. And this is your PCL fibers here. These are the PCL fibers running medially. Now let me shift my scope and let me introduce the jig. It is very important that you have a good switching stick because it makes your portal switching easier. I am switching into the anterolateral portal. I need to visualize that because we have an intact ACL and a PCL. My jig needs to go between that window. I'm here. Where's my jig? My jig is placed at about 70. Here we are. This is the window between the ACL and PCL. My jig goes there. And here I am. Now this is going to be the lateral tunnel. So I'm going to make two tunnels on either side of my PCL stump. So this is going to be my lateral tunnel. I am placing it here. This is the 10 millimeters mark. I'm going to go down there at the 10 millimeters mark. Can I have a shaver, please? I'll clear out those debris there so that my vision is still more clearer. Yeah. Is the inside picture clear enough, Dr. Madhu sir?
Yes, Chirag.
Yeah, fantastic. So I am going to clear out a few tissues here so that my vision for the audience becomes a little more clearer. I'm very thankful to my ex-fellows to come and give me a helping hands. They're my hands for today. Since I'm growing old, they told Chirag sir, we'll give you a helping hand. And I have Dr. Pratima also, who is a young dynamic arthroscopic surgeon here in Bangalore, assisting me. Here we are. So I have placed my jig or guide a little lateral to the footprint of the PCL. Now what I would do, it is about 10 millimeters from the joint line. Here it is. We have kept it at about 70. Can we have a knife, please? Outside picture, we will take a oblique incision so that we can accommodate it a little better. Here we are. Place it firm. Give me a Wissinger rod, please. I would then ask, Wissinger rod, please. I would then ask somebody to hold the capsule away from the side. Okay, hold it, please. Fantastic. Can I have grabber board next? Yeah, it is locked. Can I have a tunnel drilled? I mean, guide pin drilled. Dr. Pratima, can you help me out with that? Mallet? Okay, we're there. Not yet. Are you finding it hard? Yeah, somewhere there. That's fine. I think that should be good. It's just hitting on that. The jig mismatch maybe sometimes. Okay, let me just take a tap. Tuk tuk. That's fine. Give me mallet. Out. Out with this, Chuck. It should actually exit through the center, but for some reason, it's not exiting out through the center. Let me see if I can just mallet it, but I could, Dr. Pratima could just see that. Yeah, it should have exited out by now. No, no. Mallet, please. Going in, out, pull it out, please. There's this gentle mismatch there between the jig and the, can I have it again, please? No, remove that. Remove the guide pin. Chucky. The guide pin should ideally exit in that slot there. Dr. Sumant, can you just help? Yeah.
Chirag, are you using a flexible guide wire and a
Not
reamer?
a flexible guide wire. It's a regular beath pin. Sometimes it does happen with the usage of the jig. It can be a small mismatch there. Okay. Can I have it again? Can I have the, we'll take, come on, firmly attach it, please. Yeah. This is not locking, so maybe that's one of the reasons why. Can I have the tunnel a little more lateral? Yeah, fantastic. Yeah, it is not locking. This jig is not locking. Okay, come on. Yeah. Come on, drill one more. No, no, no. We are having a little tough time here with the jig. The jig has a mismatch. Come on, out. Yeah, it's taking some other route, which is not expected, but I'm not sure why. Can I have the jig again? Yeah, come on. That's good. Hold this, please. Put it in the dustbin.
Chirag, what angle have you kept on the?
I've kept 70. So here I am. Okay, fine. There we are. That's my lateral tunnel. Look at that. That should, how it should lock. Yeah, come on. The cadaver body also has a very strong bone. Impressed. He must be taking vitamin D and calcium. Huh? Not going? Give me a sharp beat pin, please. Give me a sharper beat pin. This is the least expected step where you can get stuck up. But of course, without, come on, can I have? Chucky. Chucky is inside. Guys, is there a phone? Neeraj, Chucky is inside. Chucky and Dr. Ranji. See the Chucky, please. Yeah, come on. Easy. No. Yeah, yeah, done. Okay, this is what was all expected. Chucky, please. Out. Gloves for Suman, please. Yeah, we are good. Now what I would do, once I've exited out here, I would then keep the jig there and drill a 4 millimeters. Can you see the bead pin exited out there? Can I have a tuk-tuk? Mallet? Mallet? Yeah. Okay, fine. So now I would take a 4 mm guide pin. Yeah. I would drill a tunnel on the lateral side of the footprint. Keeping this in mind, one could also use a kind of a grabber. Can I have a grabber? One could use this Vissinger rod to keep the capsule apart, away like this. or else protect this with this jig like this. That is what I would do. Come on, drill. Or use a grabber and hold the tip of the guide pin.
Chirag, this
Phone
tunnel
guide.
is on the lateral side of the PCL.
Yeah. I'm making the first tunnel on the lateral side. Yeah. Come on. Yeah, we can go. Yeah. Done. Out. Out. Just keep out. As much 1 second. Don't remove completely. Give me a beat pin reversed. Since I've drilled a tunnel here, lateral is what? Tunnel, lateral blue. Okay. Can I have, hold this please. So it's very important you plan your surgery. Can I have the chart there shown? So there you are. In the PCL tunnel, I would use a blue thread for my, for the tunnel, blue thread for the lateral tunnel, and ethibond for my medial tunnel. So I will show what exactly it is, and I'll show you the importance, why you need to do that. Now here is my beat pin reversed with a kind of a blue thread, and not to lose the hole. Out. As you're here, out. As that beat pin is exiting out, I'm here. Can I have a grabber? Messenger rod out. Not a, I needed a grabber, not a nice tong. Here I am. That's fine. I need to catch hold of one of the threads and pull this. Wait 1 second. Retriever, please. Switch retriever.
You
Here you are. Okay. Fantastic. So I have pulled out my lateral tunnel thread. That is the blue one through my posteromedial portal. Now I keep the jig there. As I've kept my jig there, I will then make a medial tunnel which is medial to the midline. Can I have the fitching stick, messenger rod? Are people following what I'm doing?
yes, Chirag.
Yeah, fantastic. Can I have this thing here? Here we are. I'll
Any
hold the
questions
capsule
from the
down.
audience?
I will keep the jig there. Now we need to
Any
have another tunnel.
any questions from the audience?
Are there any audience left after lunch, or are they still having lunch?
All are present.
That's nice. Then I should hear some questions. Yeah, here we are. Hold this. Can I have the bullet? Now this is very important. See, you always use a locking bullet. Can you show the bullet? See, so the first thing why we struggled was they gave a smooth bullet. Especially in these cases, you cannot afford to have a non-locking bullet and to lose your tunnels. Madhuri, come here. Hold. The bullet with the ratchet here, that goes and locks. It's very important that we have something like that. This is the medial tunnel. So let me go middle. Yeah, fantastic.
Chirag, what is the distance between two tunnels?
There's no set
On
distance as such. So I would just eyeball it. I would just be medial to my PCL. Can you see that? That's the edge of the PCL. That's the medial border of the PCL. And I'm in the medial, just medial. Can we appreciate that? That's the medial
yes.
margin of my PCL. And I am just flush in the medial border. And this is your 10 mm mark. Okay, come on. Yeah, can I have the drill? Second cortex. Are we there? Should we? Come on. Give me a chucky, please. Chucky and a mallet. Go. Yeah. I just lost the track. 1 second. Let me just get rid of this. Dr. Akshay, don't just leave that a little free. Okay. Now let me just have a look at the breath pin. Where is it? Yeah, exited out there. Good. Can I have a grabber? Give me a grabber, please. Out. This thing out. Out. Yeah. I will grab this so that it doesn't penetrate further. Yeah, 6 mm, reverse breath pin. I will always color code my tunnel. Yeah, go inside. Go, 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 go. Out, 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 out. Not fully. This is a blue ethibond. So my lateral tunnel is with the blue colored ethibond. As I'm exiting out, exit out, exit out. It's very easy that we lose the tunnel sometimes and get stuck up with this. So it's very, yeah, out. So I always keep that breath pin. And here we are. The thread. Can somebody rotate that, please, for me? One second. Can I have it rotated? Yeah, I need to grab that. I would have preferred an eye stong rather than this. Yeah, here we are. So I've done with half my job. The major chunk of my job is done. 2 tunnels on either sides of the PCL. Can you see that? That's the PCL fibers. Can somebody appreciate that? That's
Chirag.
that's your PCL fiber in between the 2 threads. Since it's an intact PCL, so the PCL fibers are there. Next, what we do, what is important? Yeah. What do you want? Can we just show the outside picture here?
We can
So
see.
here also, I have adequate space between the 2 tunnels outside. So the tunnel is not coalescing. So I can either use this as a suture bridge later, or else probably there's about, I have about 4 millimeters apart from the 2 tunnels. Now let me go into my intraarticular work of the PCL fixation. Come on. How do I do that? I will show you a simple trick to do that. I would, yeah, that's a PCL fibers. Drop the foot down. Come on, guys. The table is too down. Come on. Give me a loaded, the medial portal one. The medial, can I have that shown? PCL blue for the medial. So if my blue will go with the PCL. I will take a shoulder scorpion. Can somebody show me this? Outside picture. A shoulder scorpion loaded in the center so that I get a luggage tag suture. I would introduce it through my medial, anteromedial portal with a cannula in situ. There we are. That's my PCL stump. I would take one suture here. It's not taking a bite. Load it again. Load it again, please. Instruments sometimes is a challenge. Patan Madhuri, center part rehta. Come on, put it in the center. Put it in the center. Yeah, come on. Give me. Keep another scorpion ready in case this is not working. So here we are. I'm taking the shoulder scorpion and taking a bite through the stump. I'm taking a larger chunk on the medial side of the PCL. This doesn't seem to be working. Come on, shoulder scorpion doesn't seem to be working. Shoulder scorpion doesn't seem to be working. Yeah. I'd open this, take a bite. Here we are. I've taken a bite, rounding up the PCL. And can I have the outside picture? Outside picture, outside picture. Look at that. I would then
we can
put
see.
this inside like a luggage tag suture and then pull it. Now inside picture, look at that. That takes the entire stump of your PCL, one. Now, what I will do is I will take another, one more, ethibond loaded. I'll take an ethibond loaded for the medial side, for the lateral side. Here we are, here we are. Can somebody flush it, please? Can somebody flush it, please? Yeah. Okay, fantastic. That's done. Hold this, please. Again, the same replica. I'm going to use it like a luggage tag. Suture. Yeah, good. Now what I'm going to do here, kindly give me a eye stong. The blue is for medial or lateral? Blue is for lateral. Blue tunnel. Blue tunnel lateral. So this goes, no, this goes into the medial side. This goes into the medial side. So the blue PCL medial, here we are. I am pushing it in there. And the ethibond, I'm going to be pushing it in there. Now I would shift my portals again into the posterolateral portal. Come on, guys. I would then retrieve my blue thread. I need both of them. I need to grab both. Yeah, come on. Only the blue. I've got one. Okay. Here is the other one. Yeah, here. I've got there. So this is my medial. And what is medial here? What is medial here? In the tunnel, which is medial?
Ethibond.
In the tunnel, ethibond is medial. Hold this. So I will tie this to the ethibond. I'll tie this to the ethibond thread, which is outside.
You
Can I
mean
have the
the
outside
blue,
picture?
Chirag? You
Yes,
mean the
sir.
blue fiber wire goes into the ethibond?
Yes, yes. So tunnel, which is the medial tunnel? Ethibond, no? Okay. Here we are. Can somebody give me an artery, please? Here we are. Sometimes even I do get confused, so I usually write it off so that, and then pull the ethibond down. Here, 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 here. Okay, fine. Fantastic. Now give me that, give me the eye strong. Or else it's fine, it's fine. Pull one porche. Okay, now next, I need to find my ethibond, which is inside. Where is that? Can somebody find my ethibond? Can somebody find my ethibond? My ethibond is in the center. So I need to retrieve this a little bit. It is between my ACL and PCL. So let me see if I can push it a little further. I will then change my viewing portal. My ethibond thread, which is here, that needs to go in. So I will, this is a little tricky part because you are, okay, fine. Now if I can get through the, yeah, and can I have my, this thing coming in here? Can I get it coming in here? Am I good? Yeah, fantastic. Done. Now, can I have the outside picture? I have drawn the, yeah, can we get it tied? My ethibond gets tied to the blue thread. Outside picture, please. Outside picture, please. It gets tied here. Yeah, so PCL avulsion fracture is probably not a very common surgery which we do, not a day-to-day procedure which we do. Can you see that? Can you see that? Coming in, coming in. Yeah, fantastic. That's, there we are. So I have had a crisscross configuration here. Let me just show this here again. Can you see that? There's a crisscross configuration of my,
Yes,
can
Chirag.
this be appreciated? So
Yes,
my
Chirag.
blue thread, give me a probe, please. This is the posterior part of my PCL. This is my PCL stump. This is my PCL stump. This is my blue thread going into the medial tunnel and my lateral thread going into the lateral tunnel here. It's a crisscross configuration of my tunnels and my threads. Can you see that? We are just pulling it down. As we pull it down, this is the PCL stump, which is just sitting down. Of course, it's not an avulsion, so I cannot really show an avulsion for you, but this is how it would fix. And next, let me go. You may be having a doubt, like what happens? I have taken a bite where superior. What happens to the threads? Can we see that? See this, this is the PCL and the threads have gone sunk well below there, down. It goes down like the luggage tag is gone, holding the stump of the PCL in either ways, in either sides of, this is the blue thread and this is the green thread, which is gone down and sitting down into the tunnels. Now next, how do you fix that? I would keep the knee in 90 degrees of knee flexion. Swivel lock, please. Hold this. Knife, please. Hold this. I would usually fix all my avulsions, like my root avulsion, my ACL avulsion, PCL avulsions, everything with swivel lock. I don't like that the suture disc because you may tend to lose the tension. So here we are, SL, 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 SL. Give me a swivel lock. Okay, this is a modified swivel lock. So they have some innovations here. Knife, please. Knife, please. Artery. Outside picture, please. Inenchina Madhuri. This swivel lock is handmade. Okay. Come on. Yeah. I don't think the threads go inside this. Can I get it pulled? Yeah, fantastic. So here we are. This. Wait 1 second. One more. All the 4 threads. Can I have the outside picture? The swivel lock is compromised somewhere. Eyelet. Yeah. Eyelet is sitting now. Yeah. Can I have the outside picture? So here we are. I am going to hold this. I'm not going to over tension it. Just hold it there and introduce my swivel lock, punch, punch, punch till there, and then lock it with the screwing mechanism. Sometimes if it's an osteoporotic bone, it's better to have your other modalities of fixation. But for me, knife please, for me, swivel lock in younger patients is the go-to fixation modality for these kind of avulsions. Here we are. Of course, this is probably Just a demonstration of the fixation. My PCL there, the stump there, and probably looking into the posterolateral portal. Here we are, the threads well seated and with a good tension. If I would just feel for the PCL here, that's your PCL with my sutures well below. This is about the joint line. The tunnels are almost about 10 to 12 millimeters below, and that's a crisscross configuration where my footprint is seated back. That gives me a wider coverage area than having your kind of a parallel configuration of your sutures. Yeah, saying that, I think I should sign off now. Hope I didn't confuse the audience too much with this too many suture managements. Yeah, of course, it's a little difficult surgery to understand and to probably perform. So I think I've done my best to make it look and sound easy.